After the impression material has set, we can remove then the provisional and the implant analog is maintained in place. After attaching the standard impression coping, we can basically just need to fill up the crevice, the remaining crevice, with autopolymerizing acrylic resin, or if you prefer with light curing composite, and therefore create an exact contour of the subgingival profile of our implant provisional restoration. Inserting this and then performing a pickup impression leads to an exact transfer of the clinical situation to the dental laboratory, and from this point on it is very easy and straightforward for the dental technician to manufacture an exact replica definitive abutment on the master cast that then is used to stabilize the tissues in the position they were maintained through the provisional restoration. What is a clinical recommendation, not necessarily scientifically proven, but recommended by many authors, is also, if this approach is selected, an additional subepithelial connective tissue graft to increase even more the volume of the soft tissue at the time point of implant insertion, and immediate provisional insertion should be performed just to overcompensate slightly for further on expected remodeling of these ridges. Now, if we look into our scientific evidence for this approach, do we really obtain a better final end result? This needs to be questioned, because when we look into into studies and when we look into the final outcome, it is not necessarily the final outcome we see within 1 year post-surgery, but it's important to re-evaluate these patients after several years, 5 years, 7 years, or even 10 years, to see if the tissues are still as stable and the outcome is as predictable as was anticipated. So therefore, one of the objectives for the future is certainly to initiate different long-term follow-up studies where different protocols are compared to each other. However, if we can select an approach where we do not need to augment, where we do not need to do extensive additional surgeries, but we can basically maintain biology as is, we also reduce the risk for recession due to scar tissues. We use the neighboring dentition to stabilize the tissues, and therefore we can provide with this approach a very predictable outcome in regards to tissue stability. However, again, looking at a 3-year recall is an interesting finding. Looking into these cases after several more years will be even more interesting, just to see if the tissues are maintained. And whenever we look into science, whenever we look into different treatment options, for example, as in this case, the immediate single implant treatment and the recession of the surrounding tissues, it is mostly, when we look a little bit more into detail into these studies, that this protocol, or the patients included, are a very specific clientele. So one approach is not necessarily applicable for all patients, and it is basically still unclear, especially when it comes to aesthetics, what different treatment modalities impact our final outcome long term. Now, a different approach that has surfaced in recent years more and more, as we have a better understanding of the biology around the implants, for example, the adherence or the sealing that we want to achieve with our prosthetic components, as I have explained in lesson 1, is certainly to insert our definitive prosthetic restoration as early as possible. By talking about a prosthetic restorations, I am not necessarily talking about the crown, but most importantly, when it comes to implant restoration, certainly to create this effective barrier through our abutment. And the abutment in these cases then, if we, for example, apply a protocol that is termed the one abutment, one time concept, means that we insert a definitive abutment at the time of surgery and never basically remove this abutment afterwards.